Okay, today, I wanted to talk about heart disease in children. Welcome everyone to Paediatric Teaching, and I wanted to speak about heart disease in children. There's so many different things we could talk about in regard to heart disease. In fact, this is the second lecture we've had on heart disease, and last week we talked about reading the ECG, and it might seem strange to start with just an understanding of how to read an ECG, but I think it's a skill that's really important to acquire, and it really helps when we are trying to make a differential diagnosis and understand the different causes of heart disease and heart failure at different ages with different presentations. And I want to continue that today, not so much talk about the ECG, but talk about heart disease in children presenting in different ways at different ages. And I think if we have a good understanding of what types of heart disease present in the neonatal period, what types of heart disease present in infancy, what ones present later in childhood, then you can really hone down your differential diagnosis and look at the clinical features and the X-ray changes and the ECG and really make a diagnosis. And of course, it's good to have echocardiographic skills as well, but you can make many diagnoses by just the clinical features, taking into account the age of the child, the history, the clinical examination, and then the chest X-ray and the ECG findings. So let's go through a few aspects of heart disease in children. I was going to talk about mostly acyanotic heart disease in children today. We'll talk next week about cyanotic congenital heart disease, but I wanted to talk about heart disease in children that was largely acyanotic, and I'll explain what that means as we go on. So it's always good to sort of bring it back to a case, and I wanted to start with three cases that present. They all are heart disease, but they all present in different ways at different ages. And this is useful for those who are doing the exam in terms of exam practice, because there's a process in the exam called extended matching questions, where you get a scenario like this, and then you have to identify what's the most likely diagnosis. So we won't be really practicing extended matching questions today, but you can see how they're relevant to an understanding of a clinical differential diagnosis. So the three cases, I'll just very briefly explain them, and then we'll go through the different types in detail. So the first one is a 4-month-old boy who presents with poor weight gain, so failure to thrive, and recurrent wheezing. He has sweating and fast breathing on feeding. And that's the clinical presentation. That might be all you know to begin with, but already, if you know about heart disease, you can sort of put this in a certain, that you can understand the types of conditions, the types of heart disease that might cause this, and also the non-cardiac differential diagnosis. This is very important, that you don't just focus on this is heart disease or this is not heart disease, but think about the non-cardiac differential diagnosis. We'll go through that. Is that issue about, is it heart disease, is it lung disease, is it something else, applies to almost all these presentations. The second one is a 5-day-old girl who presents with poor feeding and shock. This girl was term. She was well at birth. She had normal APGARs and went home with her mother on day 2, but she then became lethargic and had fast breathing and couldn't feed. And when you see her, she's got peripheral cyanosis with cold, pale limbs, and her pulses are difficult to palpate. So that also could be a form of heart disease, or it could be a non-cardiac diagnosis. And what you need to know is the types of heart disease that might cause this particular presentation at this particular age, and also think about what the non-cardiac causes of this presentation are. And then the last one is a 12-year-old boy who presents with high fever and difficult breathing. He has tachycardia, a pulse that's irregular in rate and volume, an apex beat that is prominent and palpable in the 6th left intercostal space in the mid-axillary line, and crepitations in both lung fields. He has an oxygen saturation of 92% on air, and he's pale. And again, this presentation of a child of school age, a 12-year-old boy who presents like this, can point to a certain type of heart disease or several different types of acquired heart disease. And it can also point to some non-cardiac problems. So I guess in each of these, I want you to think about the most likely heart disease that would cause these presentations and the possible non-cardiac diagnoses. So we think broadly, and we don't focus on just one type of disease. Don't jump to conclusions. So we'll go to the first case now, and I want to explain a bit more about this particular type of problem. So this was, as I said, a 4-month-old boy who presented with poor weight gain and recurrent wheezing and sweating and fast breathing on feeding. So a relatively common presentation. A child presents with recurrent signs of acute lower respiratory tract infection with wheezing and respiratory distress. When he presented, his pulses were, you could feel them, but they were low volume, I would say. And he had wheezes and crackles in his lung fields, and he had hepatomegaly, and that was his chest X-ray. Now, of course, the most common cause of this presentation is not heart disease, but probably for every 20 children you see who've got pneumonia or acute lower respiratory tract infection like bronchiolitis, this looks like this has the clinical picture of bronchiolitis, acute viral bronchiolitis. But for every 10 or 20 cases, maybe 20 cases, you might see one child who has a non-respiratory diagnosis, and they might have a cardiac diagnosis. And the most likely cardiac diagnosis is, can anyone suggest what the most likely cardiac diagnosis would be in a child who presents like this? 4 months old, poor weight gain, recurrent wheezing, sweating, fast breathing on feeding. What could this child have? Yes, Ms. Burrow, Rachel? Well, the sound is not coming through very well, but okay. Well, let's think about it. I mean, again, this child could have bronchiolitis, acute viral bronchiolitis, but there's a few things that are not typical. Sometimes they have hepatomegaly, or they seem to have hepatomegaly with bronchiolitis, but that's just because their liver is pushed down because they're hyperinflated. They'll have wheeze and crackles, won't they? The crackles will be generally coarse and sound like lots of secretions in their chest. As I said, they might seem to have hepatomegaly, but actually it's not their liver's enlarged, but it's just pushed down. They generally don't have a murmur, but it's often very difficult to hear because you hear lots of crackles throughout their lung fields. It's really hard to focus on just a murmur. They won't have evidence of cardiomegaly on their chest X-ray, but again, that can be difficult. They may have hyperinflation, so their heart size will be normal, and they'll have a normal ECG. Sometimes it's very difficult to make to distinguish between bronchiolitis and what's the next diagnosis, like a ventricular septal defect. Probably a few times a year, you'll see a child presenting with what looks like bronchiolitis, and actually they've got a ventricular septal defect that might have been previously undiagnosed, because they will present in a very similar way. They present with wheeze, and they present with wheeze. You might think, well, they don't have asthma or bronchiolitis, but they present with wheeze because they've got congestion of their lungs. And not only do they have congestion, like the fluids filling up the alveoli, but it's also making their bronchi more edematous. The mucosa of their bronchi are more edematous, so you get some airflow obstruction, and therefore you get wheeze. So it's common for babies with a VSD, a large VSD, to present with wheeze. They also have crackles, of course, and as you get probably a bit more experience, you're able to make a distinction between fine crackles and coarse crackles, but it's hard to start with. but the fine crackles of just pulmonary edema compared with the coarse crackles of lots of mucus and secretions from bronchiolitis, there is a distinction, but it's hard to tell at the start. And they also have hepatomegaly, but it's real hepatomegaly. They may have a slightly toased liver as well, a pushed down liver, but they generally have a congested liver. But they might not if they have only a mild degree of congestive heart failure, which sometimes they do when they present. Babies with a ventricular septal defect, like a respiratory virus, and so they may have both a respiratory viral infection and a ventricular septal defect. So that's just a trick. They're likely to have a pansystolic murmur that's best heard at the lower left sternal edge. And like this previous child, I showed you the X-ray shows cardiomegaly, and it also shows pulmonary congestion, doesn't it? You can see the pulmonary congestion. They're not hyperinflated black lung fields like you typically see with acute viral bronchiolitis. And it's not also the atelectasis that you see commonly in children who've got bronchiolitis. If you see patchy consolidation in children with bronchiolitis, it's often because they've got linear atelectasis or a little bit of consolidation or a little bit of pneumonitis. But this looks like it's diffuse, it's bilateral, it looks like pulmonary congestion, and the heart is very big too. You can see how the heart is large and abnormally shaped. That this child had a VSD, and they will have. We talked last week about the ECG changes in children who've got, or infants who've got, ventricular septal defects, and this baby also had left ventricular hypertrophy on the ECG. Why? Because the left ventricle is having to push much more blood through the pulmonary circulation as well, and over time the left ventricle hypertrophies. The other possibility is that it's a cardiac problem, but it's not a ventricular septal defect. So anything that causes a large left to right shunt can cause this presentation. So, but a bit less common. But large patent ductus arteriosus can have the same clinical features of wheeze and crackles, but generally, instead of having low volume pulses, almost always a patent ductus arteriosus, the babies will have high volume pulses. They'll have bounding pulses and a wide pulse pressure. We've talked about this before, but their pulse pressure might be their blood pressure might be, say, 90/30 with a pulse pressure of 60, which is a wide pulse pressure, and their pulses may feel bounding, like as if they've got a hyperdynamic circulation. They're the clinical bedside features of a PDA, and that can sometimes enable you to make a distinction between a PDA and a ventricular septal defect. And of course, they'll have a continuous murmur as well. So these three conditions, bronchiolitis and ventricular septal defect and a PDA, are quite common, but you can make a distinction at the bedside in terms of the likely diagnosis based on the clinical features and the chest X-ray and an ECG. This was the ECG of this child I just showed you, who had a 4-month-old baby who had ventricular septal defect, that cardiomegaly and pulmonary congestion. And you can see, I hope you can see from the talk we gave last week, that the clinical features are of left ventricular hypertrophy, but we'll just briefly go through it again. This child is in sinus rhythm because there's upright P waves in lead 1 and AVF, they're upright. There's a normal PR interval because there's less than 3 small squares from in the start of the P to the start of the R wave, right? So it's a normal PR interval. The QRS complex, the width of the QRS is normal, isn't it? Because it's 2 small squares or less, so that's normal. There's no evidence of a bundle branch block or anything like that. The heart rate is about, what have we got? 2 large squares, so the heart rate's about 150, about 150 per minute. The axis, remember we said it's the net deflection in lead 1 and the net deflection in lead AVF. So it's probably minus 6. We talked about this last week, and plus maybe 5, 10, 15, 20, maybe 20 minus 5, which is about 16 or 17. So it's plus 16. So you already know that the axis is in a slight right axis deviation. And then we're looking at the ventricular, the chest leads to see if there's evidence of ventricular hypertrophy. And just eyeballing this, you can see that the lead in the S wave in V2 is rather large, so 5, 10, 15, 20, 25. And the R wave in V5 is also quite large, 5, 10, 15, 20, 25. So we're already up to close to 50. And you can see that that's left ventricular hypertrophy. We won't go through that again because we talked about that in a lot of detail last week, but I hope you can see that this ECG supports the chest X-ray, it supports the examination findings, and it supports the history of a child who presents at 4 months of age with recurrent respiratory distress and wheezing and failure to thrive. That's the way you can make a cardiac diagnosis. We won't go through this again. I wanted to just touch on the clinical features of heart failure, because I think sometimes we don't quite distinguish the different types of features and what they mean. There are some general features of heart failure in children. And of course, we know about tachycardia and tachypnea and sweating with feeding. So babies feed and then they get rather sweaty because they've got heart failure. It uses up a lot of energy. And so it's like physical exertion for them. And then failure to thrive. These are common general features, systemic features of heart failure. And then but then I want you to try to make a distinction between those clinical features, examination features, and history features that are suggestive of congestive heart failure. That means when the ventricle is not functioning very well, but you've got a backflow of blood, high pressures through the venous circulation, and therefore, if you've got higher venous pressures, you've got a high, what's called an end diastolic pressure. So the left ventricular end diastolic pressure is high. So the venous pressures in the pulmonary veins and in the systemic veins, the inferior vena cava and the SVC are high. And that leads to an accumulation of blood or the slow flow of blood. And that's what congestion means, doesn't it? It's the systemic circulation or the lung fields are congested. And you can have right-sided congestion and you can have left-sided congestion. So making that distinction, it's not so important, but in terms of understanding the pathophysiology of what's going on for a particular child, you can make that distinction and say this child's got predominantly right heart congestive failure, or has got predominantly left heart congestive failure, or has got evidence of biventricular congestive failure. And so the clinical signs of right heart congestive failure are anything that results from high venous pressures in the systemic circulation. So hepatomegaly, because the liver drains to the inferior vena cava and drains back to the right atrium, or edema, generalized edema, that's a sign of congestive right heart failure, or a raised jugular venous pressure, of course, sign of congestive right heart failure, because the SVC, the jugular veins drain into the SVC. I just hope you can make that sort of distinction. And then some children present with predominantly left heart congestive failure. And if you think about if the left heart's failing, then the veins that are congested are the pulmonary veins. So that child will present more with tachypnea and grunting and crackles in their lungs because of pulmonary edema, and maybe signs of an effusion. They'll have maybe a pulmonary, a pleural effusion related to heart failure. So again, it's not that important, but if you can get good at this and start thinking about, well, what's left-sided congestive heart failure, what's right-sided congestive heart failure, what's biventricular, left and right, congestive heart failure, then it will just help you describe better the clinical features of heart failure in a particular patient. Now, not all those features will be present in all children, and for some children, it's really hard to see their jugular veins. So it's not always easy, but if you look for these features and then try to understand what they mean, then it helps you much more. And then there's signs of, so that's congestive heart failure. And the other type of heart failure is low output heart failure. And sometimes low output heart failure is often a more advanced type of heart failure to congestive heart failure, but there are also certain cardiac anomalies that lead to immediate or abrupt low output heart failure. And they're not as congestive in nature, they're more low output heart failure. We'll talk about them in a little while. But the clinical features of low output heart failure are like hypotension. If you've got low cardiac output, that is, instead of the pulmonary veins being very congested, just the ventricle's not functioning and it's not pushing blood out. The stroke volume is very low. And so it's not pushing blood out to the systemic circulation. So you'll have hypotension, you'll have weak pulses, you'll have often a narrow pulse pressure because when the blood pressure is low, that stimulates the catecholamines to cause vasoconstriction to maintain the mean arterial pressure, and it stimulates the renin-angiotensin system to cause vasoconstriction. So you get a constricted circulation, and therefore the pulse pressure is very narrow. I hope that makes sense in your understanding. But if you've got a very high catecholamines circulation or high angiotensin levels, then your blood pressure, which might be normally, let's say, 90/60 or 90/50, might then become 70/60. So you then have a pulse pressure that's quite narrow, only 20, whereas the normal pulse pressure might be 40 or 50. That's what I mean by narrow pulse pressure. You can tell a lot by the blood pressure and the pulse pressure. These children who have low output heart failure will have cold peripheries and skin mottling and often oliguria, their urine output's low. And so sometimes when we see children who've got heart failure, rheumatic heart failure or whatever, it's very important that we determine if they've got signs of low output heart failure, because these children are in their developing shock, aren't they? Whereas sometimes they may present with just signs of congestive heart failure, but no signs of low output heart failure. Their blood pressure may still be okay, they're still passing urine, they're warm, and their pulse pressure is normal, and they're in a less advanced state. And so I think it's very important that we look for each of these signs and understand what they mean in terms of the types of cardiac problem, but also the stage of the cardiac problems, the stage of the heart failure. That's what I'm trying to convey. Now, that's what I've just talked about is understanding the clinical features of heart failure and what they mean in terms of whether it's mild, moderate, or severe, or very advanced, or in shock. The next thing I wanted to talk about was a way to think about the causes of heart failure. So, and the causes of heart failure, I mean, you all have a number of different causes in your mind, but I want you to try to have a framework for thinking about, a framework in your mind for thinking about the different causes of heart failure. And you can there are many different frameworks, but this is the one I use because it sort of makes sense to me, what are the parts of the heart and what can go wrong? I think that's what I find it easier to think about. And so the first thing is, well, the heart can be normally formed or not normally formed. And so the first type of heart failure causes are like where you've got structural congenital heart disease. And that can be, I think it can be broken up into cyanotic and acyanotic. So today we're going to talk about acyanotic heart disease, ventricular septal defects, etc. But these are all morphologically abnormal. By morphologically, that just means structurally abnormal. The development of the heart is abnormal. So just think about that. So some form of congenital heart disease, and then the question is it cyanotic or acyanotic? Then the next category I like to think about the other, even in a normally formed heart, there can be abnormalities of certain different components, acquired abnormalities or congenital abnormalities. So abnormalities of the valves, so valvular heart disease could be rheumatic or it could be congenital. And then you can have problems of the heart muscle itself. I don't mean holes in the heart, I mean a structurally normal heart, but there are problems with the heart muscle. And they can be either acute inflammatory, like myocarditis, or some form of congenital muscle problem, like a cardiomyopathy. And there's lots of different types of cardiomyopathies, a myriad of different types of cardiomyopathies. You don't need to know about all the different types, but just to know that they're all problems of the heart muscle, and some of them are acute viral inflammatory related, and some of them are congenital in nature. We'll talk a bit more about cardiomyopathy as we go along. And then the next structure in the heart, well, not the next one, but think about, could it be, there's the valves, there's the muscles, there's the conduction pathways, and this is important because some abnormalities of the conduction pathways can lead to heart failure, like a severe tachyarrhythmia. That can lead to heart failure. And then there's pericardial disease, and we see a lot of pericardial disease with tuberculous pericarditis or Staph aureus pericarditis, and it's just important to think about pericardial disease and not only think about it when you've got a massive globular heart, but just think about it as a cause of heart failure. And then there's probably less common heart failure that's secondary to lung disease. And we do, again, see that quite a bit in children who've got chronic lung disease, chronic bronchiectasis, or TB or HIV-related lung disease. They may get heart failure. And that's usually, to start with, of course, right ventricular failure, right heart failure, cor pulmonale, or sometimes they have primary pulmonary hypertension or pulmonary hypertension secondary to chronic lung disease. And then there's high output cardiac failure, so from severe anemia, and less common from beriberi. It's less common in PNG, but is seen quite a bit in other countries in Asia, and then rare things like large AV malformations, which lead to high output cardiac failure. We see quite a bit of high output cardiac failure related to severe anemia. The reason to categorize heart failure like this is that it helps you then think about the clinical features that would be associated with each of those causes, and then how to, when you're taking history and doing an examination and looking at an X-ray, how to hone down to narrow your differential diagnosis. Okay. So I wanted to briefly talk about acyanotic heart disease, to go back to congenital heart disease and talk a bit about acyanotic heart disease. There's sort of two large, broad types of acyanotic heart disease, and there's a bit of overlap, but we've talked a bit about ventricular septal defects. That's just one type of left to right shunt, the commonest, so it's the one that's important to know about. In an exam situation, you're most likely to be asked about ventricular septal defects, but it's important to know what the other types are. PDAs, patent ductus arteriosus, of course, is more common in neonates, in preterm neonates, but it also does occur as a form of structural heart disease that can persist even in term babies, but it's much less common. Atrial septal defects are very common, but less likely to cause heart failure, but sometimes they do. And sometimes if they do, they're associated with other abnormalities like ventricular septal defects too. So atrioventricular septal defects, and it's a spectrum between VSDs, ASDs, and atrioventricular septal defects. But they're all left to right shunts, where the blood is abnormally shunting from the left side of the heart, either the left ventricle to the right ventricle, or the left atrium to the right atrium. And then the second type of acyanotic heart disease are left ventricular outflow tract obstruction. Now, I call them acyanotic because conceptually they're acyanotic. They're just a blockage, a partial or complete, sometimes, blockage to the left ventricular outflow tract. Sometimes these children present with cyanosis, though. They present with peripheral cyanosis or even central cyanosis because the forward failure is so severe that no blood, no oxygenated blood is going to their peripheries. These children with left ventricular outflow tract obstruction have the classic form of low output heart failure. And I'll talk about an example of this in a little while. They have the classic form of low output heart failure, LVOTO, left ventricular outflow tract obstruction. Today, I'm not going to talk about cyanotic heart disease. We'll do that on another day. Well, I've mentioned ventricular septal defects, and I don't want to go over it again because I just want to give you a flavour of what VSDs, how they present and what they look like. But I guess a few key points. They don't present at birth, so you won't get very rarely will you get a baby presenting with a VSD at birth. They usually present somewhere between 2 and 6 months of age, but sometimes I've seen children of 5 years of age who've had an undiagnosed ventricular septal defect, and they have it just because it's a very small VSD. It depends on the size. If you've got a very large VSD, they may present as early as 2 months, that in severe heart failure and failure to thrive and poor feeding. If you've got a moderate sized VSD, they might not present until 4 to 6 months. And if you've got a very small one, it might be just considered to be an incidental finding when a child has their chest examined. They present, as I said, with failure to thrive and tachypnea and sweating on feeding. That's the commonest presentation of children, infants with ventricular septal defects. We've gone through the clinical features on history and examination, but I hope the clinical features make sense to you. It's because of increased pulmonary congestion from their left to right shunt. They may present with a parasternal heave, or they may have a parasternal heave. Remember I said they have a large left ventricle because the left ventricle's got to pump a lot more blood. The blood's got to, some of the blood leaving the left ventricle obviously has to go out the aorta, but a lot of it goes across the ventricular septal defect into the right ventricle, through the pulmonary arteries and the lungs, and then back to through the pulmonary veins into the left atrium and back to the left ventricle again without going systemically. And so this we've talked about this before, but this type of situation means that the pulmonary blood flow may be 1.5 to 2 times the systemic blood flow. And that's why you get such severe pulmonary congestion, because you've got so much blood flow going through the lungs that a lot of it becomes edema, pulmonary edema fluid. We've talked about the different types. So you can have very small mid-muscular VSDs. They're the most common. They often present with an incidental murmur, or they present late with tachypnea often. Sometimes there can be multiple. So often in surgery, it's thought there's one VSD, but when they go to operate, there's multiple VSDs and they have to close them all. Sometimes they can be large and present early, as I said, and sometimes they can be perimembranous, which just means it's close to the ventricular membrane. A perimembranous VSD is relatively common too. This is another X-ray, different child who you can see the common clinical features: a big heart with pulmonary congestion. That's how children commonly present with a ventricular septal defect. The cardiothoracic ratio in this child was greater than 0.6. It should be less than 0.6. So the largest diameter of the thoracic cavity and the largest diameter of the heart should be less than 0.6 in children. but it can be in a ventricular septal defect with pulmonary congestion and heart failure, it'll be more than 0.6. Just know that. I've spoken before about the reasons why children with a VSD present and go into heart failure, and it's mostly because of the drop in pulmonary vascular resistance that leads to an increase in blood flow. Remember, whether the blood flows left to right depends on the pulmonary vascular resistance relative to the systemic vascular resistance. If they're the same, then no blood will flow. If the PVR is lower than the SVR, then the blood will flow to the path of least resistance, or more blood will flow to the path of least resistance, and you get more blood flowing to the across the ventricular septal defect into the right side of the heart. And remember, the things that reduce PVR are anemia. So if a child's anemic, then more blood flows, that reduces pulmonary vasoconstriction, and more blood can flow from the left side to the right side of the heart across the VSD, and that causes more heart failure. And sometimes if you give the child oxygen, then they will have a larger left to right shunt, and that can worsen their heart failure if they've got a large VSD, right? And that's the only situation really when giving oxygen can actually worsen heart failure and worsen oxygenation is in the infant who's got a large VSD and they're a bit hypoxic, and you give them oxygen and it drops their pulmonary vascular resistance further and they get more pulmonary blood flow. They're the only two main things. Okay, we've talked a bit about this, about how this is what happens if you've got low blood pressure or low cardiac output from any source, then that leads to the kidneys detect low blood pressure. There's low renal blood flow into the kidneys, and they produce more renin, and the renin gets converted by a liver enzyme called angiotensinogen to angiotensin 1, and that gets converted by a lung enzyme called angiotensin converting enzyme to angiotensin 2. And angiotensin 2 is the strongest vasoconstrictor in the body, so that leads to an increase in blood pressure, and remember, a narrow pulse pressure, to maintain perfusion pressure to the kidneys and the brain and the heart. You get a higher mean arterial pressure, but the clinical feature is a low pulse pressure. And angiotensinogen gets converted by the adrenal glands into aldosterone, or converts into aldosterone, and that causes increased salt retention and increased water retention, which again increases the blood pressure. So this renin angiotensin aldosterone axis in the body is very important for a response to heart failure, and it is also responsible for why we see the clinical features of heart failure that we do. We see edema, which is water retention and salt retention, and a narrow pulse pressure, etc. As it gets worse, these features get worse. So it's just useful to understand, I think, the clinical features of heart failure and the pathophysiology, like the endocrine basis for that. And it's also useful to understand this because there are some agents, some drugs that block this. Of course, angiotensin converting enzyme inhibitors. When we give captopril or enalapril, we're blocking this pathway at this step, angiotensin converting enzyme, which reduces the amount of angiotensinogen in the circulation, so therefore reduces vasoconstriction, therefore will reduce blood pressure and reduce the salt and water retention. So this is captopril and enalapril are fine if you've got an adequate blood pressure, or you've got a normal blood pressure or a high blood pressure. They're not good, of course, if you've got a low blood pressure. So good treatment for hypertension, good treatment for heart failure if the blood pressure is high or normal, but not good if the blood pressure is low, and especially if the diastolic pressure is low. There's another class of drugs that are called angiotensinogen receptor blockers, which actually came into use a bit more during COVID, and these will be more available for the treatment. I think probably even in adults, they're more being used now in many countries throughout the world as an adjunctive treatment for heart failure and hypertension. They'll be more available, but at the moment, just know how ACE inhibitors work. The heart failure treatment, you all know, I won't go through this in too much detail, but we give diuretics. They reduce salt and water retention, they reduce the preload on the heart, and they reduce pulmonary congestion. So they have a variety of good effects. And then there's afterload reduction, so reducing the mechanism that I talked about before, that systemic vasoconstriction that leads the heart to have to do more work. If you reduce afterload, then the heart doesn't have to do as much work to produce the same amount of stroke volume and cardiac output. So enalapril or captopril. Then there's basic supportive care such as nutrition, ensuring the child's not anemic, which puts more strain on the heart. And then for some children with heart failure, digoxin can be useful, but really it has very limited uses these days. To children who've got extreme tachycardia, if they've got great problems with rate control or they're in atrial fibrillation, then certainly AF, it's very useful, but mostly digoxin is not very useful. Mostly if you've got fast AF, but otherwise not so useful. In children with a VSD, there's some indications for surgery, and it's really a failure of medical treatment. So if the heart failure is not controlled by medical management, not easily controlled, then those children need surgery, or they'll go into worsening heart failure. Despite medical management, the children have failure to thrive, or they're just losing weight, then they're indications for surgery. I won't talk about the others, but persistent pulmonary hypertension and a couple of other conditions that ventricular septal defects can be complicated by, that can lead to worsening heart failure, and they're indications for rapid surgery in these children. But mostly it's failure to thrive and heart failure that's not well controlled by standard medical management. I won't talk too much about atrial septal defects because they're very common, but they're less common causes of heart failure. But they can cause problems in early childhood, but it's much rarer. Atrial septal defects are of several origins, several types. Sometimes it's a mid-atrial septal defect, and sometimes it's much lower down on the atrial septum. The hole is lower down, and that can sometimes disrupt the mitral valve. If you've got an atrial septal defect that's very low in the atrial septum, then you can get regurgitation of the mitral valve. So sometimes children who've got ASDs also have mitral valve disease, and sometimes they have problems with they may also have a VSD associated with it. But a simple small ASD or simply produces a high pulmonary blood flow of a usually a small degree. Sometimes they can lead to heart failure if there's associated VSD, and sometimes they can lead to pulmonary hypertension if they are not detected and the child grows up with just high, low-grade pulmonary blood flow. And that can, I've seen a child of the age of 12 who got Eisenmenger syndrome because of high pulmonary blood flow simply from a missed atrial septal defect. So they're important to pick up. The clinical features are of a pulmonary flow murmur in the upper left sternal edge, and that's just increased flow across the pulmonary valve because there's high blood flow. So the blood flows left to right, left atrium to right atrium, then into the left ventricle. And then what the murmur is because of a high flow across the pulmonary valve here. And that's why you hear it in the second upper left sternal edge. And you, because of the very high flow across the pulmonary valve, you get delayed closure of the pulmonary valve. And that leads to a wide and fixed splitting of the second heart sound. If you listen to enough ASDs, you can detect that a wide and fixed splitting of the second heart sound. An ASD will sometimes be associated with a right bundle branch block, depending on where it is. If it's very low down in the atrial septum, then sometimes you get a right bundle branch block, but not. That's usually because of a enlarged right ventricle. If you've got a high enough pulmonary, a high enough blood flow through the ASD, then you have a volume load on the right ventricle. And over time, that can lead to hypertrophy of the right ventricle, which can lead to a right bundle branch block. And remember, we said last week that a right bundle branch block is characterized by an RSR pattern in the right ventricular leads. So V1, 2, and 3. Remember, they're the ones that look at the right ventricle. And so if you see a wide QRS and an RSR pattern in the right ventricular leads, lead 1 and lead 2 and 3, then think there could be a right bundle branch block, and you might wonder why that is. And sometimes that can be associated with an atrial septal defect because of it's just been going for so long and the right ventricle is hypertrophied. When you've got an ASD, the left ventricle is not involved, is it? Very in the pathology, because all the blood, the pressure flow is to the right ventricle, or the high flow is to the right ventricle. The third type of left to right shunt that I wanted to just briefly touch on is a PDA. I've talked a bit about that before. So excuse me for just one minute, and I just need to do one thing, sorry. Yeah, I just wanted to briefly talk about a patent ductus arteriosus. And remember, I said that they mostly occur in neonates, and they present a bit like a VSD with poor feeding and tachypnea and poor weight gain. And the clinical feature that's characteristic is this bounding pulses and, again, a wide pulse pressure. So in a newborn baby, the pulse, the blood pressure might be 55 on 18, so a very wide pulse pressure, and they also often have hepatomegaly. You can usually make the diagnosis of a PDA by the murmur, a continuous murmur, and by the pulse pressure and the bounding pulses that a child, a neonate, has. Sometimes PDAs close spontaneously, even of course in preterm babies they often close spontaneously. Even in term neonates, a PDA may close spontaneously, but not so much if they're in heart failure, but they're more likely to close if you get their heart failure under control. So with diuretics and fluid restriction, etc. They may, in preterm babies, it's well worth using a prostaglandin inhibitor, because prostaglandins are what maintain the patency of the duct. So using indomethacin or ibuprofen, whatever non-steroidal anti-inflammatory drug you've got is useful. There are some risks in very preterm babies, and you've got to watch that they have adequate renal blood flow and that they don't have signs of necrotizing enterocolitis. But usually a few days of indomethacin is fairly safe. It's useful to correct their anemia. If a baby with a PDA has anemia, then there's much more flow across the duct. And so if you bring their hemoglobin up to a normal hemoglobin for a newborn baby, so it might even be 12 to 14 grams per deciliter, then the gradient across the duct increases. So you've got a higher resistance in the pulmonary circulation, so less likely that the blood will flow from the left to the right side. Sometimes these babies need surgical closure if that medical treatment fails. I won't talk about AV canals today, but in too much detail, except that you should know that atrioventricular septal defects occur more common in children with Down syndrome, but they can occur in other children as well. ASDs and VSDs occur commonly together in otherwise normal children, but when you've got an atrioventricular septal defect, sometimes called an endocardial cushion defect, this whole area is often abnormal in its development, and you often have a abnormal mitral valve development as well. And those children present in early severe heart failure. If you've got a large AVSD, then they present in early severe heart failure, and often also with cyanosis, because the blood is just mixing between the left and the right heart. You've got a large ASD, a large VSD, a mitral valve prolapse, and the blood just mixes between the left and the right ventricle. And these children have severe and early pulmonary hypertension, and they often have cardiomegaly on chest X-ray, like a large VSD. And just like with an ASD, they'll often have a right bundle branch block, and they may have a left axis deviation. Don't need to worry about that too much, but just know that the child who presents very early that looks like he or she's got a VSD might just have an atrioventricular septal defect with both an ASD and a VSD. Okay. Look, it's coming up to 1 o'clock, so we might actually stop there. We've talked today about ASDs and VSDs and PDAs. We might stop there because I think there's a lot more to talk about in terms of heart failure, and we might talk about it next week. I think go through the other types of acyanotic heart disease. I'll send around the slides, but we'll go through the other types of heart failure, I think, next week. So thanks for your, well, I'm happy to, we might stop there because I've talked about a lot of things, and you might have some questions you want to ask about that.